welcome to MMV's celebration of its 25th anniversary and the launch of our strategy for the next 6 years, which coincides with the last 6 years of the Sustainable Development Goals. Bonsoir et bienvenue à le symposium de MMV qui célèbre notre 25e anniversaire et aussi le lancement de notre stratégie pour les prochains 6 ans qui est coïncident aussi avec la fin des ODD. Moraho, Murakarinese. Nikwa Andrea Lucar. Try to be trilingual when you're only bilingual. Nikwa Andrea Lucard, and I am the Chief of Strategy at Medicines for Malaria Venture, and we're delighted to have you here for our symposium. Over the last 13 years, I've served MMV in various capacities. And if you count ages as you might, the age of a child who was born on a leap year, I am 3 MIMs old. I am Durban, Dakar, Kigali. During those 13 years, I've had the privilege to watch this organization serve its purpose to discover, develop, and deliver new anti-malarials. And during this session, we're going to bring forward our strategy to you as coming forward. But first, I'd like to describe for you how it is that we decided to launch our strategy here at MIM. So as we were thinking in 2023 about what it was that we wanted to do for our strategy and for our anniversary, it was clear from our colleagues, there was a clear consensus that it should be done here with you, our partners at MIM in Kigali. So what we've done here is rather than deciding on having a really large party, we've decided to dig in and to be part as much as we can of this community, to provide financial and technical support to the degree that we can to the organizers, because this is a very important place for us to be. And so you will see us here, not just supporting. Someone said earlier today that you couldn't sit down at a session at MIM without sitting next to somebody who was from MMV. And it's done intentionally because we really do believe that this is an important place for us to launch our strategy, not just really here right now at this session, but also symbolically. I'd very much like to thank the local organizing committee for allowing us to be part of this, and for the government of Rwanda for inviting us. Murakoze. So, for those of you who are not familiar with MMV, I'll describe us very briefly. We are a not-for-profit Swiss foundation that was formed in 1999, and it was birthed out of great urgency. And it was the urgency of the vast antimicrobial resistance that was gripping the world at the end of the 20th century. And that antimicrobial resistance was anti-malarial resistance. The pipeline was almost empty, and the drugs were failing. And so we were birthed out of tropical disease research, which this year is celebrating its 50th anniversary. And we're very proud that our spin-off is one of their many accomplishments. The design of the organization was to be the hub, the connector, the weaver, the accelerator for the discovery, development, and delivery of anti-malarials. It was designed for us to bring together the scientific, medical, financial, industrial might of the global malaria community, of global research, toward this very thorny problem of how do we replenish the anti-malarial pipeline in the face of vast resistance. You'll hear more about that now in our session as we come forward, how we're planning on approaching that in the next 6 years. And to help us do that, I'd like to first introduce 2 distinguished guests. First, I'll introduce one, and then she'll come, and then introduce the other. So I'd first like to introduce Madame Joy Pumafi. If you've been to any sessions in this conference, you've likely heard Joy introduced. You may have heard her introduced as the young health minister in Botswana at the height of the HIV crisis, when at a mere 30 years of age, she went to the United States and refused initially by a major donor to bring ARVs to her country, went and found other partnerships to make sure that the citizens of her country had access to the same medicines that citizens in the North had. Or you may have heard her introduced as the head of ALMA, which is an organization which now comprises 55 African heads of state, focused not only on malaria, but also on maternal, child health, contraception, and NTDs. But I'd like to introduce Joy as an MMV board member. And I've had the privilege and the pleasure of working for and with Joy over the last 13 years. She serves as an inspiration for us at MMV, not just for me. I can tell you that we've put together recently an inspiration board at MMV, and Joy is named on it multiple times. And she serves as an inspiration for us because she has retained the fire and the fearsomeness of her activist self, combined with the diplomacy and coolness of somebody who can reach the highest levels of government. She continues to serve her legacy in this by bringing up the next generation of activists and diplomats. So Joy, I'd like to ask you to come up to the stage with wearing whatever hat you would like. Activist, entrepreneur, mother, grandmother, diplomat, and certainly MMV trustee.
Thank you. I think with this podium, I'm also a bit short, which is interesting. Thank you so much, Andrea. And I would like to recognize Rwanda's former minister, my brother, Daniel Ngamija, who is now leading the global community as the head of the Global Malaria Program in WHO. And I want to recognize our partners who are with us here today, SMMV, who are so critical in the fight against malaria. But I would really like to pay homage as well to the MMV staff. A robust team, fearless, and totally committed to the fight against malaria on the African continent and around the world. I have the honor, on behalf of the board of MMV, Medicines for Malaria Venture, of welcoming you to this symposium that, as you have heard from Andrea, will shine a spotlight on exclusive strategies, inclusive strategies, comprehensive strategies to meet the new challenges in malaria over the next 5 years, providing you with MMV's vision of where it wants to go. All of us present at Africa's largest malaria convention, MIM, know that the disease has proven to be stubborn and to be wily. It has proven from generation to generation to define the lives of communities, particularly the poor in our communities and disadvantaged. Malaria is a destructive force that compromises earning and learning potential and that compromises economic development. It is a complex disease, continuously evolving. We have pitted our wits and intelligence against it. And as Andrea has just shared with you, in some cases, we have managed to quell its lethal impact. But the parasite sometimes finds a way to work against whatever innovation that we come with, and that sometimes it seems to be implacable. But what we must be certain of is that it can be beaten, and that we will beat it. What is clear is that, however, we cannot defeat malaria as individuals and as individual stakeholders, as individual countries, as individual organizations, as individual institutions, as individual experts. We can only beat it together. We must be coordinated. We must be multi-sectoral in our approach. We must be multi-community. We must be multi-stakeholder. It doesn't matter where the stakeholder is working, whether they're a scientist, whether they're a politician, whether they're a student, whether they're a researcher, whether they are a teacher, whether they are a doctor. We must work together, forge strong partnerships, fueled by science, fueled by our determination, across all countries, geographies, and organizations, harnessing and deploying our multiple skills, our expertise, our tools, and technology to defeat this foe. These partnerships are getting stronger by the day because you are committed to them. I know MMV well, and as a member of the board, committed to the discovery, development, and delivery of new tools. MMV's development products that have been introduced into our communities, products that I'm calling development products because they are helping our communities to develop. A sick mother is not going to be able to teach a child, is not going to be able to earn income, is not going to be able to make a living. And sick workers are not going to contribute to gross domestic product. So the products have protected, treated over 1.2 billion people. They have saved an estimated 15.4 million lives since 2009. That is a massive achievement. So we must recognize today the power of a partnership model. MMV has crafted a vision for the next 5 years that will be shared with you today, anchored on strengthening and broadening these partnerships that it has created over the years, partnerships that are going to help all of us to achieve a malaria-free world with equity as a pivotal lens throughout the new strategy that responds to urgent needs, not the urgent needs of us, but the urgent needs of the people that we seek to serve, the women, the children, the communities that are driving this vision. The needs such as drug resistance, the needs such as climate change, the needs such as new vector control mechanisms that are required, the needs such as the increase in the drivers of the incidence of malaria, the needs such as new vectors such as Anopheles stephensi that are coming into our communities. So let us today listen carefully, but let us also commit. This vision, this strategy that will be shared with you today is not an MMV strategy. It is our strategy, and we look forward to partnering with you to make it our success. Thank you.
Thank you so much, Joy. Activist, communicator, fighter for all of us. It's my pleasure now to introduce, as Joy just did on my behalf, Dr. Daniel Gamije, who's the head of the Global Malaria Program. MNV has been working with the GMP shoulder to shoulder for the last 25 years. We work together on scientific, academic, access, advocacy, communications, to bring together our shared vision and for us to implement our part of the global technical strategy. When I had the opportunity to meet Dr. Gamije on Sunday, when he and I were serving on a panel together on malaria and gender, I didn't yet know at that time, Dr. Gamije, that you had been the Honorable Minister of Health, Rwanda. And the first thing that I heard was that you had identified Awa Kolsak as your hero, as your Shiro. And I thought, here's a man who sees, who understands, and who will bring us to where we need to go. And then I learned that you were Honorable Minister of Health during the COVID crisis, which is the most unenviable position, and yet one that, as you were describing the Rwandan meaning of your name, Kinyarwanda meaning of your name, which is described as resilient, striving, determined. And I thought, yes, we will be able to continue to work with the GMP as we have under this leadership. Thank you so much for being willing to come and speak with us today. And please come and take the podium. Please welcome Dr. Gamije.
Thank you. Thank you, Andrea, for these kind words. My sister, Dr. Joy, and my boss, because she's the chairperson of RBM board, and I'm a member of the board of RBM. Colleagues from MMV and all participants, I'm really delighted to be in this session where we'll get more information about the strategy that MV developed and allow me to give few remarks that I prepared. 25 years ago, the international community pledged to reduce the burden of malaria. An estimated 2.1 billion malaria cases and 11.7 million malaria deaths were averted globally in the period from 2000 to 2022. This is according to the last World Malaria Report. But today, malaria remains an urgent public health threat. In 2022 alone, we reported 249 million cases of malaria and 608,000 deaths, mainly among African young children. Not only malaria is still with us, but progress to reduce case and death numbers is off track. Putting malaria control efforts back on track will take a major global effort that draws on multiple interventions, including vector control measures, vaccines, diagnostics, preventive and curative medicines. MMV works focus on the key role played by medicine, where historical inequities in research and development access have denied communities across the world the treatment they need, especially children and women of reproductive age. Saving these and many more lives will require investment in strong health systems with good quality, and it will require resources to ensure appropriate interventions to prevent and cure malaria for all in need. This includes medicines for malaria prevention and treatment. The recent emergence of partial resistance on artemisinin in Africa, together with possible signs of resistance to partners drugs, call for investment in new and better medicines. Climate change poses an added threat to malaria responses worldwide. In recent years, extreme weather events like floods and shift in temperature and humidity have disrupted seasonal patterns of malaria transmission. In some cases, we are seeing the emergence of malaria in previously unaffected areas. This has put population with no or low disease immunity at risk. The challenge of malaria is further amplified in settings where there is mass population displacement, conflict, and humanitarian crisis. WHO Global Technical Strategy for Malaria is a comprehensive framework to guide malaria endemic countries towards a 90% reduction of malaria incidence and mortality rates by 2030. This means working to expand access to and to maximize the impact of existing malaria medicine, as well as hastening innovation and implementation research to support the development and uptake of effective new tools. WHO is committed to support the development of new tools and their faster approval and related guidelines in a way that reforms is conducted for a predictable, parallel, coordinated, and predictable mechanism to develop guidelines and recommendations, and at the same time, having new health products pre-qualified by WHO. We have seen progress, but the tools to beat malaria need to be deployed more strategically and available to all. This can only be achieved through stronger and more equitable public and private civil society partnership. I think MIM is a good example where we have everybody together: public sector, private sector, civil society, and academicians. I don't think there is anyone missing in MIM partnership. To end malaria, it will require the commitment made during the recent Malaria Ministerial Conference in Yaoundé, Cameroon, to be translated in actions and resource to harness this partnership and deliver bold agenda. As WHO, we are proud to partner with MMV and others in an end-to-end approach that ensures that all those in need benefit from the full range of malaria interventions and quality health care services. I thank you, and to MMV, I wish happy 25th anniversary. Thank you.
Thank you so much to our honorable speakers for helping introduce this and to saying such kind words about MMV. When I was originally preparing the remarks, or actually as our communications team was preparing the remarks for us here, I was planning on actually giving you the introduction to the strategy, to speak to you about all of these things, and then have my colleagues do the same thing. But the day before yesterday, at the booth, MMV booth, I had the pleasure of meeting Dr. Gilbert Kakwaro, who was a long time from Kenya, who's a longtime collaborator of MMV, but not someone I had the pleasure to meet. So we were talking outside the booth, and he was describing some of the work that he's doing right now and how he's trying to bring strategy and planning and other activities to researchers and to organizations. And he said, the problem, Andrea, Dr. Kokoro, I don't know if you're here. I can't see very well, and if you are, I'm hoping I'm going to paraphrase him correctly. And he said, Andrea, the problem that we have in Africa is that when we develop strategies, we do it from the top down, and then the people who are supposed to implement the strategies don't buy in. And then they don't buy in, and the work isn't get done. And I said, oh, Dr. Kokoro, you're not talking about Africa. You're talking about all of us. So I decided instead that I would change, Lizzie, I'm sorry, I'm changing your notes, but I would like to talk a little bit about how MMV has brought this process of our creation of our strategy to try to get over this basic problem we all seem to have in the construction of the strategy, which tends to be a bunch of us smart people sitting in a room and then deciding what it is that we're going to do and then asking a few people and launching it. And then wondering perhaps why we're not quite on track. So instead, in 2022, what MMV decided to do was to really look at the environment in which we were working and to try to understand where an organization that had been designed as a hub, a connector, a weaver, an accelerator of malaria drugs, where we should be operating. The world is changing rapidly, and one of the things that we decided we first needed to do was come out to the community, not just the malaria community, but more generally to say, what is our role, and how should we think about this? So what we began to do was quite a process that took us almost 2 years of coming to many of you at this conference, many of you in the room, and asking that question. We went to our industrial partners, we went to NMCPs, we went to the WHO, we went to RBM, we went to researchers in the South, in the North, in the East, and the West, and we asked that question. And it took us quite a while. And when the answers came back, there were a lot of ways of looking at this. And so what we did, rather than just sort of going, oh, this is too much to do and there's too many things to think about, instead what we did is went into the organization that had all 120 of us, or thereabouts, from the receptionist to the CEO, to look at these questions and say, are we looking at this the right way? How do we group these things, and how do we understand what it is that we need to do next? And in the end, where we came down was grouping the answers in approximately 3 different ways. The first was to look at where is the world going, malaria and not malaria. As Daniel was just saying, where are we looking in terms of climate? We know that this is a massive problem. And yet, in health in general, not just malaria, we've been slow to think about our strategies in relationship to climate. We then came back and said, well, in other areas where we're looking, also geopolitical uncertainty, the loss of funding, a sense of health, not taking the kind of priority it needs, and yet becoming broader overall. The next area where we began to see the writing and what we needed to do was to think about ourselves really in the place of malaria drug development, delivery, and access. And there it was a question of saying, what are we hearing from our partners? And we heard a couple of things that were really interesting. The first one was, don't lose focus. This is still a major problem. So please don't leave us without your focus in malaria drug development and delivery. But at the same time, we also heard that they need us to be thinking, they, you, we, need to be thinking about these questions really from end to end. And from end to end meaning, as we're thinking about delivery, what do we know and what are we feeding back into discovery? And you heard this morning, if you were there for the plenary session, you heard people asking the question, so how are you thinking about delivery in a monoclonal antibody which hasn't even hit phase 2? How are you thinking about the uptake of insecticides? Don't stop thinking with the end in mind and feeding back. But the other thing that was quite interesting that we heard was also recognize that malaria has a lot to offer the rest of the world. There's been research in this field for a very long time, and the epidemiology of the disease is such that we have a great deal of data. So please don't just stay in your malaria silo, but begin to think about how you can contribute to the rest of the global health problems. Not just global health, as we think about diseases of low and middle income countries, but conditions that affect all of us in wealthy nations and in those not so wealthy. And finally, we heard some very interesting threads that came through, and that was, please think about how you're doing this work. Don't just think about what you're doing and why you're doing it, but how are you doing it? How are you making sure that when you're designing your products, the most vulnerable people in the world are at the forefront of what you're doing? The people who are most underserved, pregnant women, infants, people at the remote reaches in the Amazon or in the DRC, think and be sure that what you're doing provides access. And then be sure that the people who are doing that work are reflective of the people who are, in fact, themselves the beneficiaries. Are you sure that younger researchers are named on your papers? Are you sure that women are in decision-making places? Are you sure that less resourced institutions are part of the decision-making? Be sure that your how reflects your what and your why. Be sure that you keep climate in the center of the work that you're doing. And as we learn more, be sure that you're understanding how we can all contribute. And finally, be sure that what you're doing is sustainable, that you're creating sustainable and equitable partnerships that are going to last a long time, that you're thinking about how the funding is going to operate. You're thinking about new ways of bringing funding into the field and new ways of sharing the resources, new ways of making partnerships so that we can do that. Christina earlier today in her comment said MMV loves pillars and waves. Actually, I love weaving. And so I love to say I'd like to see this all as a beautiful tapestry. But for now, what I'd like to do is indicate that what we have done is we've brought together four pillars of curing patients, preventing infections, eliminating malaria and contributing to the end game, and working beyond malaria. And we're doing that with a cross-cutting priorities of making sure our medicines are accessible, that equity is built in from the beginning, that we are dealing with climate issues, and that it's sustainable. So to do that, rather than hearing any more from me, what I'd like to do is invite our colleagues who are going to describe each one of those pillars to come up to the stage. And the way that we're going to run this is that we're going to have a dyad. We're going to have someone from MMV and one of our partners, each to describe how MMV is facing some portion of these challenges. So if I can ask MMV colleagues and partners to please come up to the stage and array yourselves. Yeah, come on, don't be shy. I've been up here for 5 minutes, you can do it. And partners, please. Saka, please come up as well. So sit, for our partners, if you just sit next to your MMV teammate. Yeah, good. Great. I said at the beginning of all of this, when we were working on this at MMV, that this was not going to be classical music, this was going to be jazz. So we are improvising just a little bit. So I would like to, first of all, introduce our long panel. And what I will do is to move through this from curing, preventing, eliminating, and beyond malaria. And I'm going to introduce my MMV colleague who's going to lead the first part of the discussion, or make the first presentation, who will then introduce our partner. And so I'll begin with Dr. Viveka Kushupska, who is the Vice President for Development at MMV. Please, Viveka.
Thank you, Andrea. I hope everybody can hear me okay. So I'm going to start with with curing patients. So let me first say that it is a tall order to describe the strategy that we set out for ourselves for the next few years in a few minutes. And I think all of my colleagues are going to have the same challenge. But somehow I got lucky with curing patients, because after all, curing patients has been at the heart of the malaria community and MMV's work for decades. So you might be asking yourselves at this time, what else can we do, and what is new here? So I can assure you there will be some familiar themes, because the work has to continue to build on what we are already doing. But as with any strategy, we have to be ready to respond to the current challenges. And there isn't a greater challenge that's been discussed at this conference and a more worrisome than drug resistance. So in essence, I could summarize that Pillar 1, curing patients, is all about staying ahead of resistance. So how do we propose to do that? Well, number one, we need to preserve existing antimalarials. Number two, we need to develop and deliver new drug combinations. Number three, we need to shorten the treatment regimens. So I'm going to take a few minutes and give you a few examples how we intend to do that. So back to point number one, staying ahead of resistance by preserving existing antimalarials. So here we are very much aligned with the WHO resistance strategy. Multiple first-line therapies has been a concept promoted by MMV, my Access colleagues, in fact, from the beginning. We moved that from concept to action by co-leading 2 pilot studies in Burkina Faso and in Kenya, which are now serving as a building block for the bigger consortia that are coming together. And just a couple of days ago, I was privileged to join my colleagues for a meeting between ALARM Consortium and the STAP AMDR. And I have to tell you that we were invited to continue supporting and facilitating and convening the countries to help them get over the line and actually roll out this challenging program. There are other examples where we're fully aligned with WHO, such as the triple ACT and single low-dose Primaquine plus ACT. And there we have a number of partners who call on us for expertise and specific tasks. And I just want to point out FOSN group, who we are supporting and getting over the line through the pre-qualification process with their co-packaged, co-developed, co-delivered, hopefully, Primaquine plus ACT. So moving on to point number 2, staying ahead of resistance by developing new combinations. Here we'll continue to work with our pharma partners to advance the pipeline, hopefully successfully. We have a phase 3 program with Novartis, ganaplacide lumefantrin. You might also know that we have some earlier phase 2 programs with partners such as Merck in Germany and Zydus Cadila in India. We have also novel classes which could be combined with existing antimalarials to make it a little bit faster in terms of delivery. And in all of this work, thinking about new combinations, severe malaria remains very high on our map for obvious reasons. Because if artemisinin resistance was to fully materialize, the lives of these patients would be at risk first. So we have a number of new molecules in the pipeline, and they have to be fast-acting. That is the key operative word here. And we hope to bring them at least through phase 2 so that we could be ready in case of an emergency arising. Moving on to number 3, staying ahead of resistance by shortening treatment regimens, preferably to single dose. This is important not just for the convenience of the patients, but how it connects to the compliance. And a patient who does not complete their treatment regimen is at risk of residual parasites and developing resistance. Also for elimination campaigns, it is an obvious choice to have a single delivery of a drug. But it is a very high bar for chemical entities, as you might know. But we do have molecules, promising molecules in the pipeline that are potent, that are fast-acting, that stay longer, that are refractory to resistance, and have no signals, or not worrying signals, in reprotoxicology studies in animals. And I'm going to digress for a minute, maybe less, if Lizzie allows me, on the importance of the last point of the clean reprotox profile. And that is because a key element of MMV's strategy is to intentionally include in our development programs the key target population that is often forgotten, and that is the pregnant and lactating women. And in order to do that, there is no better place to start than with candidates in our pipeline that actually have this toxicology profile, that we can then more comfortably collect data on during the development stages, such as pharmacokinetic profile, to ensure that the efficacious dose that we hope to bring to the market is actually going to be equally efficacious for pregnant women, to use latest state-of-the-art in mathematical modeling to predict the passage of drugs to placenta, through placenta, or to breast milk. And this all will allow us to continue collecting data post-registration in order to close the gap of the equitable availability of drugs to pregnant and lactating women. So it was a bit long digression, but I thought it was important to say. So I'm going to conclude now. In conclusion, MMV will continue to work to bring new treatments to cure patients, to stay ahead of resistance, and to cover all patient populations, including pregnant and lactating women. And with that, I'd like to introduce my colleague, Dr. Nikoye Otsiula, who is a Global Medical Affairs Director at Novartis. She is a very talented and capable woman. Not only is she a medical doctor with 20 years of experience, she's also a researcher in infectious diseases, worked both on drugs and vaccines. But importantly for us, she is based in Nairobi. And as such, she brings key inputs from the ground to our joint development program with Novartis, so that as she bridges the development and commercial teams and helps us do all the work that we do together in this partnership. So with that, I'd like to turn over to Nikoye.
One finger does not kill a louse. This is a saying we have in Swahili that suggests that without unity, we cannot defeat a common adversary. In this case, we're talking about malaria. Novartis is an R&D company with bench through clinical development, through access, or bedside as we call it, capabilities. And we brought the first fixed dose combination ACT to patients in their hands 25 years ago. And at that time, patients were dying of malaria. We have been two fingers in a hand with MMV for the last 2 decades. Because after bringing this fixed dose combination to patients, we then collaborated on the development of the pediatric dispersible tablet for temethylumefantrin. This has been the workhorse of malaria treatment for the last almost 2 decades. Novartis' commitment to meeting unmet needs or addressing unmet needs continues, and we have 4 projects going that we're working with MMV on. The first is to avail treatment for little babies weighing less than 5 kilos, for whom the current recommendations reflect currently available tools, which are not entirely fit for purpose due to ontogeny. We have a symposium on Friday to unpack our Kalina study, which we worked on collaboratively with MMV and Pan-Africa, and we hope that you will come by. The second big bucket is resistance. And it really, you can see the themes that are flowing between us and MMV. And remembering what I said about what was happening 25 years ago, we're extremely honored to be in a position to have something to bring to the table to address the current threat of resistance. We have the ganaplacide lumefantrin program ongoing, development program. We've partnered with MMV starting at phase 2, and for phase 3, we've been joined by the Wanekam consortium. Ganaplacide lumefantrin is a drug that, first of all, is once daily dosed, so it provides the potential for ease of use to patients, more convenience. Secondly, it's efficacious against both artemisinin-sensitive and resistant strains of Plasmodium falciparum, which is our current concern. And thirdly, has the potential for transmission blocking, which then allows use that's far broader than what we currently have in a simplified manner. As Viveka so eloquently mentioned, if we lose artemisinin, then we lose the standard of care for severe malaria. And to that end, we're working on sipagamin. It's in phase 2 of development. It's also called KAE 609. And for this, we're collaborating with Pan-Africa, funded by EDCTP, and MMV is the coordinator of this grant. Quite lockstep with MMV, we're looking towards simplification of treatment. We have a platform study ongoing that would be looking at the next generation dual or triple combinations. And the aim here is to address the need for adherence, compliance, and potentially prevent resistance, because these treatments will be working at different points of the life cycle, all with novel mechanisms of action. I'd like to note here that we're not repurposing old drugs. We actually go and do discovery, development, preclinical studies, and come through clinical development with our partners, of whom MMV is our major partner. I'm hoping in these examples you have seen exactly what Andrea said at the beginning. You've seen MMV's independence, their broad stakeholder mapping, their ability to convene these various stakeholders and unite the purpose, and their strategic and thought leadership, which they lend us. And finally, the one that Andrea just swept over, which is the co-funding of our projects. We fund them together. And this is very, very helpful, especially when you think about future access. So you sitting in the room, you might be a researcher. You might be on an ethics committee, and it's your work to review our proposals. You might be a regulator, and you review both the study proposals and the dossiers that come out at the end. Or you might be a policymaker. We've had Dr. Daniel's commitment to streamlining efforts to go through guideline review and recommendation. And our call to action is this. We would like to work towards zero malaria in a very streamlined and efficient fashion. Is there anything we can do about the hurdles? You are part of our treatment hand, and many other hands have to join together to defeat malaria because, ladies and gentlemen, one finger cannot, will not kill a louse. Thank you.
Thank you, Nicoya. It's lovely words, thank you. I realized that when I was introducing my colleague Viveka, I neglected something very important, which is to let you know that Viveka is the mother and perhaps the grandmother now, given the, no, not your children. No, I don't have news from your daughter that they're daughters that you don't know. I don't know, promise. No, but of our MIMBA strategy, which is a really, really important strategy for the global malaria world, but also beyond malaria. And I say the grandmother because you began as the thinker and founder of it, and now there's already a generation of people who are moving beyond it. And I wanted to make sure that Viveka was acknowledged. I'm next pleased to introduce Dr. Andre. I'm going to move forward on this one. I'm thinking the number of ways I could introduce Andre, but I need to be careful. Dr. Andre Chauchi, who is from Cameroon originally, and then did his medical training at the Université de Burundi. Then went to Sanofi and works at Sanofi Pasteur in Paris, and now is at. No, you're looking at me like I'm not telling the truth. Okay, that's what when you rely on Google. But I also just want to note that, that Andre has also been a major part of the organizing committee at MIM, and somebody who I'm guessing that 70% of this room probably knows. He is really a passionate advocate, activist, and leader in leading us all to think about African self-determination, leadership, and responsibility. And he will speak to you about the well, you never know what Andre will speak about, but he will speak about now on in preventing infections. Dr. Andre.
Thank you, Andrea. Thank you. Good evening, everyone, colleagues. It's really a pleasure to be standing in front of you to talk about the second pillar of our MMV strategy. I think everyone in this room knows about SMC. I'm part of that generation. When I was growing up in Africa, we used to get, at some time, one tablet at home. We used to get one tablet on our plates every Friday, if I recall, to prevent malaria before eating. So you take your tablet, if not, you are not given a meal. So that's how it was, and that was those days, chemoprophylaxis. Then at some point it stopped, and it went quiet. A few years ago, about 15 years ago, some new evidence led WHO to recommend now again chemoprevention using drugs in high, medium transmission areas. And several of these recommendations were published, but one of them, which is the one about SMC, picked up, and today it's a wide success that no one can be disputing. And in 2023, last year, we achieved to cover 53 million children with SMC, though at the beginning the estimates of SMC in total were 39 million only. So very, very basic estimates. I'm talking about all this because all this momentum behind SMC led WHO to, led the researchers first to look at other potential opportunities of prevention, and finally generating evidence and leading WHO to review their recommendation. And 2022-2023, they were revisiting SMC recommendation, extending the age or opening the age, allowing new recommendation, intermittent preventive treatment in school children, revisiting intermittent preventive treatment in infant, then IPTP is still there with community IPTP and so on. All these strategies to say that prevention using drugs today is very central in the tools that are used to combat malaria, and inevitably that should have a very key position in a strategy for an organization like MMV. So it's becoming today, just to talk a bit about integration, SMC and prevention, chemoprevention in general, it's so appealing today that talking about integration, it is used now as an entry point to tackle other diseases. So moving from the vertical approach, malaria, today we are using in Niger, for example, SMC to diagnose severe malnutrition and take actions. And these are things that we'll be thinking about to see how we can use this entry point of prevention to integrate more other disease related to childhood. Now, IPTSC, PMC, evidence are being generated. They are recommended, but they are not widely implemented yet. We should build from the success of SMC to make those other interventions as widely implemented as SMC. This is something we are doing, as usual, in partnership with all the partners, implementing partners, funding partners, the research, and so on. And that led us to lead at some time the creation of the SMC Alliance, and building from the words from Dr. Daniel about putting multidisciplinary people together. I think we succeeded with SMC Alliance, and we want to build now from SMC Alliance to create a sort of platform regrouping all the chemoprevention intervention in children. And this is part of our strategy and what we'll be doing in the next 5 years to make sure that all children eligible for a chemoprevention intervention, wherever they are, can get this intervention. And of course, we are doing that in partnership with our manufacturers. This needs drug, and sometimes huge volume of drugs. I've been talking about 53 million children, and those 53 million children will need 4 or 5 doses of drugs. So definitely the capacity production of the manufacturers needs to be going alongside with that. Now, it's not perfect. There are tools that are there. MMV is focusing on drugs, certainly, but we all know they are malaria vaccines now. And we need some studies have demonstrated synergies. Now we need to see how the drugs that are coming from MMV and the partners can be used alongside on a more efficient way on the field to achieve better results again, because synergies have been demonstrated to be better than each of the tools used alone. So this is something that also will be looking on the implementation side, how is that feasible? And of course, advocating because we are in an environment where the resources are becoming limited. So we have to work to see how optimally we can deploy all those resources to be the most efficient possible. Cost effectiveness, of course, will contribute to that. Now, in the story, Viveka just talked about resistance. It's not just about curing patients, because most of the drugs that are used for chemoprevention now are very old drugs. So there will be a need to find a replacement solution. This is the work of MMV to look at innovations and so on to anticipate on resistance. So in the pipelines with our colleagues from R&D, there are options in the pipeline that are coming, and we should be ready in the access department to prepare the ground to accept those new innovations. So as I was talking about manufacturing, there will be a need to improve availability, accessibility, and affordability, widening the options of manufacturing. And with Africa CDC today, there is a motto and there is a motivation about developing local manufacturing. And in this perspective, we have been starting the work. And it is therefore my pleasure to introduce Mr. Palu Danani, who, with 40 years of experience in the pharma, he's the managing director and the owner, the founder of Universal Limited in Kenya, based in Kikuyu in Kenya, with whom we managed to get to pre-qualification SP and SP amodiaquine. But it's many years of experience of pre-qualification, and we would like him to maybe share the experience of pre-qualified manufacturing from based in Africa and working for African and working on products for Africans. Welcome.
Thank you, Andre. Well, it's a pleasure to be standing in front of all of you, and thank you for inviting me to be presenting today. We were the first African manufacturer to get pre-qualified for SP and SPAQ, but that's just last year. But we have had the pre-qualification status for the past 11 years. So it's not something new that's sort of a hit and run thing. It's a sustainable model. And it's not only malaria, but we also have products including AL in the malaria strength, and we also have an HIV product, the first line treatment for HIV, which is pre-qualified as well. Just to maybe mention a few things, I think we heard that malaria, really, the major problem is in Africa, but we don't have enough manufacturers in Africa. So in the journey we went through with MMV, we just cannot say enough thank you, that with the funding that you gave us, it took us to a level that really helped us, not only the funding, but we got a lot of technical assistance, help, different ideas. Like MMB suggested, we should have a pink tablet because it's really for pregnant women, and it was really a challenge to convince WHO with a pink color. But we fought the journey together with MMV, and thank you, that was good advice. And Universal Corporation is based in Kikuyu. We are part of the Strides group based out of India. And in this particular product for SP, we partner with a company as well from RENA Exports from India. As I mentioned, we have a lot of advantages of African manufacturing. I think I'm not a technical person, so I'll not go into any clinical data and all that. But as an African manufacturer, I think COVID taught us a lot of lessons. During the COVID time, there were certain items which the donors were buying from us, and 19 countries out of the entire Africa on the continent, which were through the donors, we were supplying from Kikuyu. Whereas all the countries that were relying from imports had all shortages, huge shortages of that product. So it's always advantageous to have product manufactured near where the problem is. So I guess it's a good start. Again, thank you very much for that help and assistance. We cannot, as an African manufacturer, I think we also have challenges. Everything that we manufacture, all the raw materials, including majority packaging materials, are still imported. And the reason being that there is no domestic demand to put up plants for that. So eventually, everything will be backward integrated, and those will definitely reduce a lot of costs and timely supplies. Even right now, there is no challenge in timely supplies. We have proven that we supply on time, being out of Africa. There were cases where people were saying it's difficult to manufacture in Africa. Challenges, maybe questions were coming about our pricing, but we are not expensive. It's a myth. Yes, we'll be slightly more expensive, but due to several factors, we don't enjoy any export benefits like other countries do give export benefits to their manufacturers, which in Africa we don't expect. We have some taxes in certain countries, which makes it even more expensive. And generally, the cost of manufacturing is 6 to 7% more expensive, but it's not 6 to 7% on the selling price, on the cost price. So overall, depends on the product, how fast it's required, whether we airlift the material or not. It cannot be more than 15% and as low as 0.5% difference. So it's a myth that they are expensive. In certain cases, there are procurement agents who have bought at a higher price than what we have been supplying from Africa at. Challenges, I think, if as a group we could also think about how to facilitate registrations, because that's a big challenge on the continent. We have 52 regulators. So if you have a product, we have to convince 52 regulators. So I think that is one assistance from the group if we can get that, and especially when the product has been PQ'd, it should be quickly adopted. There is a collaborative procedure at the WHO, but I think it's still a bit slow. It needs a bit more fast tracking on that, because every country wants to be autonomous, which is good, but some assistance would be great in developing African manufacturing. When you have a population of, let's say, 15, 20 million in Rwanda or 50 million in Kenya, the volumes are not enough to make a big plant and make it more competitive. So when you get the whole, the continent at large, clearly prices can fall, or I'm not saying fall, but we will be more competitive than we are today. So please, let's not think that we are not competitive. We are definitely very competitive. Capacity. I think I heard you say capacity. Capacity is relevant to the market size that you go for. I mean, just as an example, just one company, that is us, we have a capacity of 3 billion tablets a year. So I think it's reasonable size capacity compared to the orders which we have not received till now. We have just been awarded by the Global Fund the first time, antimalarials and HIV products. Let's hope that with that, capacity should not be an issue. And obviously it takes time to expand, but many manufacturers, and I think now with the donor world talking about African manufacturing, is clearly going to see a lot of investments coming in through, and a lot of factories have started coming in already, including many expansions on people who are already existing. One request also we have is maybe governments, like Kenya government really has supported local manufacturing now. There's a list of products that they only will buy from the local producers. So like that, we expect African governments to be also supportive, and that's one message maybe we could take through the ministers for health or the heads of state. And somehow help us reduce on imports. Like if you take example of Nigeria, Bangladesh, it's really helping local manufacturing grow. And I think there is enough evidence to show that whatever is manufactured locally, accessibility, availability, affordability will all be there as part of it. I still have time. Anyway, I think I have a lot of other things I can discuss, but I'll just stop here. Thank you.
Thank you very much. This kind of challenge that you're speaking about are the kinds of challenges that we all recognize that the continent faces in preventing malaria and in making sure that the infrastructure and the industrial might of the continent is actually used in support of the malaria elimination goals. Thank you very much for being willing to be part of this. I'd like to now introduce Cristina Donini, and I recognize that we're running somewhat over time, and I hope that you're able to stay with us for a little while longer as we move through the rest of our program. So Dr. Cristina Donini, you probably saw her this morning. She is our head of research, early development and modeling, REM, which could mean sleep, or it could mean a wonderful rock group, depending on your era. And Cristina will speak to us now about eliminating malaria. She is one of these people that manages to really embrace challenges, complicated questions, and difficult questions. So please, if you do have questions, the first person always to direct them to, the more difficult they are, is Cristina. Thank you, Cristina.
So the pillar 3 is eliminating malaria, and we also say shortening the end game. I'm a very competitive person, so I'm gonna say we should not just end the game, we need to win it. And so how are we gonna do it? We have different challenges that we're facing with malaria, and when I think about malaria elimination, some of you have seen it in one of the slides I presented this morning. I like to think about elimination as a puzzle. It's a jigsaw puzzle, there are many pieces in there, but maybe from an MMV perspective, what I would like you to bring home is 3 pieces of this puzzle. It's other strain, other than falciparum. So we need to think about Vivax, Suvali, malaria. Women, pregnant women, together with children, of course, and transmission blocking. So Dr. Daniel Joy has mentioned all the challenges that we're facing in this jigsaw puzzle to eliminate this disease. We have health system that needs to be strengthened. We have the resistance, drug resistance, vector resistance, insecticide resistance. We have funding that is shrinking, or at least is stalling, and is not good news for us. There's a spread of vectors that are very adaptable. So we have seen in the WHO report how the threat of Anopheles diffensi is actually posing a huge challenge and could pose a challenge. It's coming into Africa, and it does adapt into urban settings, which is not good news considering that we want to increase urbanization. And then we have climate change. Daniel mentioned it. This is another huge threat. It's a reality. We hear about climate change day in and day out. People think that, some people think that it's not a reality, but it is real. And so we're seeing that the vector is surviving at higher temperature. We are seeing that actually, as Daniel said, we have areas that were malaria-free that actually are seeing insurgence of malaria. And we have a disaster like flooding. We've seen it in Mozambique, we've seen it in Uganda, and we've seen a huge rise in cases of malaria. So if we go back to those 3 pieces of puzzle that I would like you to concentrate on, other strains, why is this so important? After my talk this morning, I had Dr. Daniel Yilma, is one of the PI we've worked with in Jimma, in Ethiopia. And so he said, I'm so glad you talked about Vivax, because usually in Africa we don't talk about Vivax. But Vivax is there. We had another researcher that came to our booth and said to us, I'm from Senegal, I'm glad you talked about Vivax. We do have Vivax cases. So if we are thinking about eliminating this disease, we need to think about other strain other than falciparum. Falciparum is very important, but Vivax is as well. Ovale is as well. We have hotspot of Ovale, mixed infection, malaria. And so we have the success story of bringing into the market the first single dose tafenoquine for Vivax with GSK. That was a beautiful collaboration, again, collaboration and partnership. Yet we haven't got rid of the G6PD liability. And so we still need to test prior to administer. And that is not an easy thing to do. So in research, what we are doing is that we haven't abandoned Vivax, although we've been told, maybe concentrate on falciparum, but we haven't. And so, with this undercurrent things, we have kept platform working on Vivax, and so we have now for the first time 2 new chemical series that could tackle the anti-hypnozoites, which is a beautiful dormant form of the parasite that remain dormant in the liver, with no G6PD liabilities. So we screen all our compounds for G6PD liability, and we bring on only those that do not have this liability. Women, Viveka nicely said it. We need to think about women. Children is absolutely one of our top priority, and pregnant women. And women are also another priority. They're a huge underserved population, and in order to eliminate this disease, we need to have medicine that can be safely administered into pregnant women of all trimesters. And so what are we doing into that respect? If some of you was attending our MIMBA session yesterday, you've seen how we're going from end to end, from prospective studies using drugs that are available today and trying to fill in the data gap that we have in terms of safety data with these compounds. And if we go down to the left in research, we are also implementing studies and assays that usually are not done as early as, before first in human, for instance, to make sure that we are able to screen molecule, to flag molecule that could not be, for instance, administered to women of childbearing potential, and prioritize compound that actually can, in order to fill the gap that we have in terms of medicine for that underserved population. Last but not least, I think one of the major pieces of this puzzle is also the parasite loads that we have in human bodies. So I attended once a seminar that was talking about eradication of diseases. And so there was this professor that talked about smallpox eradication. That's one of the major success we have had in global health, in any disease. That was the disease that was eradicated. And he said something very interesting. He said it was easy, actually, because we could go in the most remote village, in the most remote places on earth, and we could find the last standing individual that had smallpox. Why? Because there was a clinical manifestation. Malaria is different. Any of us here in this room could be an asymptomatic carriers. So how do we treat, how do we eliminate the disease when actually we can't see it, that that person is carrying parasites? And so we have We can tackle it in two different ways. We're talking about transmission blocking. We can block it from a host perspective, so having molecule like ganaplacide, like carbamazepine, that can actually that are potent against gametocytes, so those sexual stage of the parasite that actually are going to reinfect the mosquito. So we can block the cycle there. Or, if we're going to be bolder, we can actually think about having the host that becomes the drug for the vector. And so we can stop it from a vector perspective with drugs that target the mosquito and they kill it. We've seen that there are mathematical models that are showing that actually this could be a strategy that could have a huge impact in stopping transmission, particularly in certain areas. So before handing over to Professor Isaka Sagara, that is here with us today, I just want to leave you with the message that this is a jigsaw puzzle. It's difficult, it's complex, yet if we do work together as a community from all the different angles and we commit to it, I think we can win this game. And I'm very pleased to introduce you Professor Isaka Sagara. He is the research director at MRTC in Bamako. We have a long-standing relationship with the Institute and with Professor Sagara. We've collaborated in many trials, and we aim to continue to do so with one of those new endectocides that we're trying to develop for transmission blocking. Please welcome Professor Isaka Sagara.
Thank you very much, Christina, for introducing me. Also, thank you, MMV, for inviting me to this symposium. And, of course, really the MIM society for organizing. So here, MMV asked me to talk about breaking the life cycle, as you can see on one part of their here box. So for malaria parasite, of course. And here, I will be talking on two parts in breaking that life cycles. First will be about drugs, and the other will be about transmission blocking vaccines. So for the drug parts, it will be these different studies called Nectar studies. So name of the studies, different studies, 4 studies done in Mali, led by Professor Diko and funded by Bill and Melinda Gates, and with different other partners at London School led by Chris Drackley, and also at Radboud, Netherlands, by Ten Busman. So most of those studies are already published, of course, but here about life cycle breaking, how. And the study design is that used all the almost ACTs, artemisinin-based combination used on ground, dihydroartemisinin piperakine, artemether lumefantrine, pyronaridine artesunate, and also used on ground also the prevention for children, SMC drug, sulfadoxine, pyrimethamine plus amodiaquine. So all those different drugs were compared with a control, so a placebo control for effectivity. So to do so, we screen more than 1,000 and then have people who are carrying gametocyte, 10 years and over age group participants have been selected, and then compare the different. So in summary, what will this study show? In summary, different, and also in addition to the ACT alone, the primakin has been added as an additional arm, or even another also gametocytic drug, tafenoquine, has been also added and tested. So in summary, using this, what we can say is that in any of those ACTs, when you use primakin at a relative low dose, then you block transmission, reduce or block transmission, starting 48 hours, let's say 2 days after you block transmission, and when even you follow up to 28 days, no effectivity proven, using what we call a membrane feeding assay. So that for a different ACT when you add primakin. So when you don't add primakin, then at least we have shown that artemether lumefantrine is still blocking. And even if you add Primakin, difference is not really significant, meaning that artemether lumefantrine alone is kind of, in terms of blocking transmission, is seen better. So that was summary. But when this is with, if you add Primakin, as I said, but if you add tafenoquine, then it's block also transmission, but slower compared to Primakin added on top. So SPAQ, artesunate amodiaquine, sulfadoxine pyrimethamine amodiaquine, also similar like ACT, really you can see that the blocking activity is not seen really, because like the ACT, we have shown effectivity starting and lasting more than 14 days for like ACTs if you don't add Primakin. So, but if you add Primakin, you can see the blocking activity even with SP and AQ. So, and that's the summary for that study. And quickly go back now to the blocking that transmission using the transmission blocking vaccine. Here, this study is funded by ADCP2 program. We thank for, and they funded our consortium called the PF-TBV. Consortium led at the University of Bamako with different West African countries. Some are here in this room. And the specific candidate that we used that I will be talking is about a PFS 230 D1 antigen. So in summary, we took school-age children or adolescents starting 9 to 18 years old, and when vaccinated, a series of vaccinated, 3 doses, and then after do at this time direct skin feeding assay. So, and also even boost 1 year again and did the same. So in summary, here we had, we did around on about 400 participants, and then we have seen that we are able to block around 75% of blocking transmission. And mosquitoes, when you look on blocking mosquitoes transmitting 86%. So that's the summary of the result. And for each of those strategies, next step are, for transmission blocking, now consideration and combination with R21 is planned, and hopefully next month we will start phase 1 vaccination in Mali. For the drugs, very also next step is now with what we call the indectocid, so long life drug. That will be used to see how also this can be studied and block that transmission for a long period. So that's the direction for future. Thank you for your attention.
Thank you very much, Dr. Segarra. You can see now how complicated this is from our perspective as we're trying to weave all of these aspects together. And our role as a weaver, as a hub, as a way of thinking this. And our partners themselves are doing the same thing. So we're talking about multiple drugs that we're trying to provide, where Novartis is looking at a whole portfolio of products, where Dr. Segarra is talking about vaccines and drugs. It's really a very complex place where we're all working together and trying to find the interface, the interstices of this. Even as we're doing this in malaria then, we have the last area that we're going to discuss here is what we heard from the community about what we're doing beyond malaria. Because you've heard it just now a little bit in where it's coming up, where Dr. Andre was speaking about how we're thinking about chemoprevention across all children in all areas, where Dr. Viveka is saying, how are we thinking about malaria as it relates to other disease areas? So Dr. James Duffy is responsible for drug discovery at MMV in an area in particular with our African partnerships. James comes to us from the United Kingdom, where he was did his studies and also worked for a number of years. came to MMV and then disappeared for a little while, not long after you came. And he came back not only with a beard, but having spent a year at H3D in South Africa. And really, when I spoke to him this morning about how to introduce him, he said, "It's changed my whole career. It changed my whole way of thinking about how we're going to get to the end game in malaria, which is to really be focusing on catalyzing and bringing together drug discovery in Africa." So James, if you would come to the podium and then give us some more on that. Thank you.
Well, good evening, everyone, and thank you very much, Andrea, for that very kind introduction. So tonight, I'm going to talk about the fourth pillar of the new MMV strategy, what's beyond malaria. My co-presenter, Susan Winks, and I are going to describe a vision of how we can exploit 25 years, the 25 years that MMV and our partners have built together, the 25 years of knowledge, the 25 years of experience, the 25 years of passion and drive, how we can embrace new tools and new ways of thinking, how we can work together not only to reduce the burden of suffering of malaria, but also the burden of suffering of diseases beyond malaria that also disproportionately affect vulnerable populations. So where am I going to start? I'm going to start with AI and machine learning. Now, AI, or a machine mimicking human intelligence, and machine learning, or teaching a machine to perform tasks, routinely involving pattern recognition to provide information that's more accurate than otherwise obtained, are buzzwords. But what do they mean, and what do they mean to me? So if you indulge me, I will give a story. As Andrea said, I was fortunate enough to spend a year on secondment with Susan and her team in Cape Town. Shortly after I arrived in Cape Town, I went to get my lunch. As you can see, this is a slightly tangential story. And when it came to pay for my lunch, the cashier said, "Well, do you want to use SnapScan?" And I looked at her blankly. What are they talking about? And for those of you who don't know, SnapScan is a mobile phone-based digital wallet, similar to M-Pesa in Kenya or OPay in Nigeria or thousands of others that now are all around the world. But at the time, in 2018, in Switzerland, very, very few people had seen the potential of this use of digital technology. However, in Africa, people had already discovered that this was a more convenient, a more secure, a more efficient, and simply a better way of making financial transactions. Now, of course, a digital wallet is not artificial intelligence or machine learning. Well, at least not yet. It may be soon. But it's actually a perfect example of how disruptional digital technology platforms have the opportunity to improve, enhance, reinvent, reimagine processes and old ways of working. And at MMV, we believe that AI and machine learning will have a similar game-changing impact on the way that we do drug discovery, both now and in the future. Researchers who use AI and machine learning will discover that this is simply a better way of doing their work. So I will give an example now of how we've used this at MMV. We've developed a tool called MAPE. Now, MAPE is a machine learning model built on the data obtained from testing over 5 million compounds against the malaria parasite that predicts, based on chemical structure, whether a compound is likely to be active against the malaria parasite or inactive against the parasite. This means that if any of you out there had a set of compounds that you wanted us to test, you could send me 1,000 compounds and I can put them into the machine and it will select me with more than 10 times efficiency over our traditional processes. So you send me 1,000 compounds, I'll feed them into the machine and it will predict the 100 compounds that are likely to be active. Now, as you can imagine, this has incredible implications on cost, on time and on resource. When you scale this up and you're thinking of screening thousands, millions of compounds, the impact is incredible. So that's one use that we have at the moment. Going forward, we realize that actually commercially available artificial intelligence and machine learning tools are often prohibitively expensive, especially for researchers working on non-for-profit or neglected diseases. So therefore, working with experts from academia and industry, we are democratizing the process. We're developing a suite of artificial intelligence and machine learning products that are going to be open access, free of charge, specifically designed for researchers in malaria and other neglected diseases, that are going to transform the way that we're going to work. They're going to aid researchers in the design of compounds. They're going to aid researchers in how to predict biological properties. They're going to aid researchers in making sharp, clear decisions. This really has potential, and I think within MMV, we really believe in MMV Discovery that the next generation of malaria drugs will have been discovered and developed by researchers who are using these tools to assist them. All of the themes, so I'm going to move on. All the themes I'm talking about tonight are linked, and the second is MMV Emerge. In essence, MMV Emerge is MMV utilizing, seizing the opportunity to use our experience and knowledge in drug discovery, in drug development, and in drug access against other diseases beyond malaria. As you've heard, working with our partners, we've had incredible success in reducing the burden of suffering of malaria. Working together, why could we not do this against a virus such as Ebola, where you have an average case fatality rate of 50%, or against a fungal, life-threatening fungus like Aspergillus, where resistance is an enormous emerging problem due to the widespread use of azole fungicides in agriculture. Or another infective parasite like schistosomiasis, with over 250 million cases per year requiring preventative treatment. Working together, we really have the opportunity at the moment to make a difference in other areas. So I'd like to leave you with really a call to action. A call to action to work together with us, whether you're a researcher, an expert, or a policymaker. We need your involvement in this process, and whether it be refining our tools, whether it will be identifying unmet urgent clinical needs, whether it will be building partnerships. This is something that we can all work on together, and we'd love to have that engagement with you. Okay, so that's my pitch. I'm now going to hand over to Susan Winks. Now, Susan is the head of Susan comes from H3D, Drug Discovery Centre at the University of Cape Town, where she is the head of research operations. Now, for those of you who don't know Susan, Susan is the glue that binds the organisation together. She is the person who has the unenviable task of translating Kelly Jabali's vision into reality. Susan and I have been collaborating for over 10 years, and whether that be on funding applications or developing young talent, or whether it be actually discovering the new drug candidates that we're actually feeding into our pipeline. During this time, we've spent many, many hours discussing the challenges of carrying out malaria drug discovery and development in an African institution. And during those discussions, Susan always relentlessly focuses on the solutions, not the problems. And I'm very pleased to say tonight she's going to give you some of those solutions. So, Susan? Would you like the microphone?
We live in really exciting times. As James mentioned, I'm from H3D, which is the first integrated drug discovery and development center on the continent. And I'm pleased to say that MMV has been a partner since day one. And now I'm completely blank. Great intro. This is why I left my notes over there. No, thank you. Sorry, it's been the end of a really, really long day, and I've just suddenly gone blank, seeing as it's 7:30 and we're all thinking about dinner. Yes, so we at H3D really believe that AI is a technology that you cannot ignore. We see it as an opportunity to accelerate research and development, and we see it as an opportunity or an imperative to help us achieve global health equity. So I'm going to talk to you today about 2 different examples about how we at H3D are actually putting this into action. And hopefully,
I can take you along this journey and leave you inspired to use these tools in your own research. So to start with, I'm going to talk to you about how we've applied and developed a tool on the drug discovery side. So for those of you who are not familiar with how the drug discovery process works, we usually start with screening lots of compounds, and those are physical compounds that you need to get. Then we will take the hits from that and we'll have to put them through, for example, cytotoxicity assays. And then we'll say, well, if they're not toxic and they're active, that's great. Are they soluble? So then we'll check if they're soluble and so on. We'll then start to do the more expensive assays and we'll say, well, are they metabolically stable and can they permeate in the membranes? And we start to build up a picture of whether or not this could be a potential drug. Now, this is what we call a screening cascade. And as you can imagine, it typically takes a lot of resources and iterative cycles to take you through this process. So what we've done at H3D is we have developed the first fully automated virtual screening cascade, which we call Zyrachem. And we have taken all the standard assays that we would use for hit-to-lead optimization and developed models which are now predictive of whether or not you would actually achieve a positive response in that assay. So what does this actually mean? It means that if we look at our data set from our malaria research, and we picked 50 compounds at random, maybe 10% of them might be active against malaria. If we ask our model that we've trained on different data, but we've trained it, if we ask it, which ones do you think will be active? The model returns a hit rate of 90% of active compounds with less than 100 nanomolar activity. To validate it in another way, because we want to know, do these models actually work? While we were developing the model, which, to be fair, took about 6 months of computational time and coding and refining, the malaria team, the project that we work with James, was continuing to optimize their program and use conventional methods. And all those compounds that they made in that 6-month period and tested while they went from hit to a compound that was active in the in vivo model for malaria, we developed all of those. So then to validate our model, we took all that data and we put it into the model. We put it into Zyrachem. We said, well, which of those compounds that we've made in the last 6 months do you think would have got there? And it correctly predicted the one that was active in our in vivo model. Now imagine that. If you could take 6 months of research and you could achieve it almost instantly just by putting those compounds into the model. This has the power to dramatically accelerate how we do research. Of course, it doesn't negate the fact that we still need to do the experimental validation. You still need to make things, but you can make the ones that have a higher chance of actually doing what you want them to do. So that's the one example of how we're using the tool. And Zyrachem is an open access tool that is available to anybody. The other example I want to give is on a completely different end of the value chain. When we start to think about the clinical application, what happens when you take a drug? So let's talk about pharmacogenomics, which is the influence of genetics on how your body is going to respond to a drug. So if I take a drug, my body and my genetics will determine how much of that is actually bioavailable in my system and how well that drug works. If you come from a different population and you've got different enzymes in your liver and your genetics are different, you might have a very different level of that drug in your system, which could result in overexposure or underexposure. In the case of overexposure, there may be toxic side effects. In the case of underexposure, the drug just doesn't work. Okay, so is this a problem? If we look at the US FDA, they currently have over 300 drugs which have pharmacogenetic advice associated with them. Little warnings of if you're from this population group or if you have this particular enzyme or deficient in it, the drug might need to be dosed differently or you shouldn't take it and so on. Of those more than 300 drugs with the advice, only 15 have been studied in African populations. Pause for a moment and think what that means. These are drugs that are commercially available to all of us, and only 15 of them have actually taken into account the genetic diversity on this continent. We know that this is a massive gap, and it's influencing how our population is responding to drugs. This is a global equity issue. If sorry, 1 minute left, and now you've thrown me again. Sorry, Helen. Yes, so essentially, the other part of the puzzle is that we know that there's a dearth of clinical trials on the continent, with only about 3.5% of global trials occurring on the continent. So we're actually not generating enough data that can be used into these models. The issue is exacerbated further by the fact that the global north is increasingly using AI models to predict how we will react to drugs. So if the African data is not fed into these models, they're not going to be relevant to our population, and the gap is going to widen. There are 3 ways that we can start to solve this. The first is we need to attract more clinical trials to the continent. We need to generate more data on African patients. The second is we need to be developing our own models based on the data that we have in Africa that can actually start to address this. And I'm pleased to say that there is a third solution, which is a technique called transfer learning, where we can take an AI model that has been developed on data from other population groups, expose it to a small subpopulation in Africa, and train it, retrain it, so that it's actually relevant and applicable. So what is H3D doing about this? What we're focusing on is actually developing new models for African patient populations using African data. So in closing, what I want to do is I want to inspire you to use these tools, inspire you to collect the data that we need to make a difference on this continent. If you are a researcher and you're not using AI tools, relook at what you're doing and see how it can help to accelerate your research. And if you happen to be involved on the clinical side or pharmacovigilance side, or even writing the ethics approvals and protocols which would allow you to share that data afterwards, consider how do we make that data accessible so it can actually inform these models to make sure that Africa is not left behind. Thank you.
Thank you, Dr. Winks. So we've come to the end of our panel presentation here, and I know that some of you need to be places, but I would like to just do a quick summary and also to first of all ask you to please once again give a hand of applause to our fantastic MMV partners who have come and been part of this work. Thank you so much, not only for coming and doing this, but also indulging us in trying to do this in the TED Talk way, which is very difficult indeed. And I would like to note that we do have a question and answer session. We did focus forward just to say that we have a commitment to you in our strategy. And this is one that Christina put up before. Our fully funded strategic plan by 2040, we intend to bring 4 new co-developed medicines to the market, to advance 30 molecules through the pipeline, to double the number of quality-assured anti-malarial manufacturers in Africa, and expand malaria chemoprevention reach. You can see it, we're doing, as Nohera said, we're not using one finger. We're using as many fingers as we can. I can't hold up all 10 and hold the microphone. But thank you for that saying, and very much, that's where we intend to go. So I'd like to end us here for right now and move into the question and answer session if I can. Thank you very, very much for your attention and for your partnership. Yes, so I'm gonna hand this microphone back.
Thank you very much for the fantastic panel discussion. I'm Mohamed Afolabi from London School of Hygiene and Tropical Medicine. I want to start by congratulating MMV on the 25th anniversary and for the incredible and amazing achievement that you have made over the 25 years. Congratulations again. I agree with my sister who says that you cannot kill a louse with one hand. We have a similar adage in West Africa. It says that you cannot clap with only one hand. So you have to use the 2 hands. And I also agree that we've been using human intelligence over the past decades. Now we can consider artificial and machine learning intelligence to achieve the end game and win the war against malaria. But I think there are some low-hanging fruits such that we do not only focus on the processes, the tools that MMV develop to achieve your vision beyond malaria. I don't know whether MMV will consider or be receptive to accept a kind of ideas, because what I see from all the panel is about integration, synergy, and equitable partnership. Are you able to accept if there are ideas from the other side, not only the one that MMV developed? Thank you very much.
Thank you. James, I'm going to ask you to take the answer to that question, but I do realize that I've made a brief oversight here, and in thanking our partners, I neglected to thank our very distinguished entry speakers, Dr. Joy, Dr. Daniel, and I would like to, just before you do that, to please also thank them very much as being champions on our behalf and leaders of our cause and our movement. Thank you so much, and thank you so much for being part of this. Please, James.
Okay. As you probably heard from my presentation, I talk too much, but I can give you a very short answer. Yes.
All right, very good. Another question from the audience. Yep, please.
Thank you very much. I'm Adegboyega Taufik from the University of Rwanda. I would like to join others to congratulate MMV and all the partners. My concern is on the aspect of R&D. Is MMV disposed to an African homegrown solution? For instance, at the university, a team of researchers recently developed a proposal seeking towards eliminating malaria in Rwanda. It's quite a very robust one. But at the end of the day, the funding opportunity was not successful. So in such a regard, is the MMV keen to meet with those researchers in addressing all the concerns that have been promoted? Thank you.
Who would like to take that? Andre? Christina, please. Christina would be delighted to take that question.
We would be delighted to. We have worked with other groups. H3 is a clear example. And so we're always keen in talking to researchers from any side of the world and discuss. And, you know, it's important not to have a tunnel view. It's important to look at it all the different angles. And we might be sometimes blindfolded. So reach out to us and we will be happy to work with you. Thank you.
Andre.
Yes, I think maybe just as a reminder, one of the principles of working of MMV is partnership. Partnership means that each of the partners brings something on the table and together we make it grow. So you can bring your solution, and if you are coming to us, it's because for you to grow that solution, you have identified that MMV can bring something on the table, and all together we grow it and for the benefits of the patients. So I think that's the basic principle of how MMV is working. We are not achieving anything by ourselves. So just that principle applies and I think answers to your questions.
Other questions? Okay. I had one for Viveka, and that was around how are you thinking that the work in malaria in mothers and babies may have synergies with other areas in which we're working in maternal, child, newborn health, reproductive health, and other places?
That's an interesting question, thank you. Well, intuitively, there are big overlaps, but I think we're finding it more difficult as an organization to reach across to these different areas because R&D is quite special, I think. There's a history of reluctance to include pregnant women early on in our thinking and strategies in drug development for good reasons, because the safety of the mother and the baby are paramount. So engaging in a global mind shift that's taking place across different diseases for the last 4 years has been quite an educational journey for all of us. And throughout that, we've reached out to different organizations and learned a lot from how they are approaching different issues and where the commonalities are. How do you recruit women in clinical trials? For example, how do you think about it differently if it's a disease of a reproductive system versus an infectious disease versus a chronic disease? So yes, I think it's been a very fruitful and productive engagement across the community.
Thank you.
Thank you.
If there are no more questions from the audience, yes, there's one right behind the cameraman.
So thank you so much. I just want to ask a question related to AI. We know that AI today is a major issue, and I'm wondering how MMV is planning to work across Africa, which most of these diseases, the burden is high, and most of these drugs are going to be used to be able to work through the ethical and the legal aspect of AI, either in terms of the last speaker on pharmacogenomics or pharmacogenetics with the broad consent issue, and as well as maybe issue of data protection or security related to AI data use. Thank you.
James or Susan?
It's a very good question, and it's certainly something that, you know, the whole area of how we use data, how we share data, how we protect data is something that certainly is being built into our plans. Obviously, as speak for myself, as scientists, we run away with our ideas, and we see the light at the end of the tunnel, and we just want to chase that. But we do have to be mindful of how people can use it, and obviously the end user, as with our drugs, will be in mind with our products. But I think that in terms of data usage, the models generally will be standalone. So I don't think there will be a problem in terms of people necessarily sharing data, though we would very much encourage everyone to share data. I think together, as we've been repeating, we're stronger than apart. So that's how we envisage. That's our vision for the AI. Do you want to speak about that?
Yes, thank you. And just to add to that, so one of the tools there's certainly different types of tools being developed at the moment, but there are ways of using data in AI models where you don't actually expose the integrity of the data. So you can still protect the personal information, but use it to train the model. And I think increasingly we're going to be using tools like that. As long as we've got the data and it's properly curated, we can set up firewalls to use it for AI models.
Very good. So I'm going to end us here. We heard at the beginning from, there's another question, I'm sorry, please.
Thanks to all the presenters. I just have one question to ask, and that is, I imagine that in the next few years, there's going to be large-scale deployment of vaccines, monoclonal antibodies, and other things. How does this fit into your thoughts about the future in terms of what you're looking at by 2030?
Thank you. Christina, do you want to take that? Andre? The question was, how are we thinking about where our role is and what our work is going to be with a potential large-scale deployment of vaccines that's coming forward? Did I get that correctly, sir? Yes. Thank you.
Yes, I think we all know all the malaria tools are not maybe target the vaccines, as you mentioned. All the malaria tools, they have limitations. So there is no unique magic bullets. And it's just by using optimally all the tools together that will achieve what we want also to achieve here as elimination and eventually eradication. So there is a place for each of the tools in the armamentum today to achieve what we are achieving. We are focusing on drugs, yes. Other organizations are focusing on vaccines, but definitely it is the same health system that is implementing it. So moving beyond the tools, we should be looking at how the health system is organized to bring together all those tools in a very optimal way so that we achieve our targets. So the expansion of the vaccines definitely is not a concern. It is welcome, and we'll be adding that what we are delivering so that we achieve those results. We expect that by multiplying the efforts, we may not need all of these in some few years, and just fighting to avoid reoccurrence or how do they call it? Reemergence, yes, reemergence of malaria after elimination everywhere. So I think all those tools, they have their place in the strategy.
Any other questions? People are hungry. Good. So allow me just to close with having now a bit of sign language that I learned today. This doesn't work. This doesn't work. This works. This works. Together, we will do this. Thank you so much for being part of this. Thank you very much.